Greetings, everyone. We're going to do the third of my 4 presentations during this block in the Radiology After 5 course, and we're going to talk about one of my favorite, if not my favorite topics. I guess to kind of paraphrase Woody Allen, he said the brain was my second favorite organ. I guess the appendix is my second favorite organ. And even though I've been examining and studying and reading cases with appendicitis for 30 years now or so, I still find this challenging in a percentage of cases, and that's what we're going to talk about today. Brooke Jeffrey at Stanford got me interested in this topic when I was a fellow out there years ago, and still interested to this day. So here's my little guy when he was a little bit younger. Now he's 4, and he's got this quizzical look on his face. And sometimes, even though I'm supposed to be the expert in appendicitis imaging, and a case comes through and I'm sitting with the residents, I'm like, oh boy, this one is not that straightforward. So no disclosures, but I should disclose that I really have been challenged by this topic in particular for many years. It sometimes doesn't seem to get any easier, surprisingly, that a non-trivial minority of CTs done for a suspected appendicitis end up being difficult to interpret. We'll go through some, but not all of these particular scenarios. And radiology really is a team sport. And again, I want to acknowledge my friend and colleague, Mike Patlis at McMaster. He contributed some cases and expertise to this. And there have been some contributions from everybody from medical students to senior people like Abe Dockman on some projects that we've worked on over the years with respect to appendicitis. So I thank everybody for their contributions. So we're going to go over some specific scenarios. We're going to focus in this lecture only on CT. And we're going to talk about some uncommon, atypical, unusual presentations, go over some mimics and pitfalls, and some of the problematic scenarios that we have encountered in real practice. We'll demonstrate examples of this, and we'll just briefly end with a comment or two about medical legal issues in appendicitis imaging. So we could spend the whole morning talking about this. I'll just be brief in terms of should we or not use oral contrast for appendicitis imaging with CT in adults, talking about adults here. And the answer is we very occasionally do. It wasn't us actually that got rid of oral contrast. It was the ER. Some years ago, we conceded most of the protocoling of the stat imaging exams to the ED. And they were the ones, based on reports in their literature and their meetings, that were eliminating it. Again, occasionally we do it. You'll see cases in this presentation where there is oral contrast on board, but I would say in the last 6-7 years, we generally don't use it. The yield has really been shown to be not that substantial in most individuals. The problem is you can't look at a patient clinically and look at their habitus, and I guess maybe you've had prior imaging to compare, but generally can't tell if it's going to add something or not. In a substantial percentage of patients, the oral contrast, even if you wait for an hour plus, doesn't get to exactly where you want it to go. There are some other subtler things, such as a slight increase in radiation dose if you're using automated dose modulation. And no surprise, multiple papers in the literature showing that if you eliminate it, you get the imaging done more